Today class is antepartum hemorrhage. In short, we call it like APH. Okay, most of the classes I have covered in the bleeding in pregnancy and bleeding in third stage of labor. This is again a class of bleeding which is related to the pregnancy. Okay, you must have some knowledge about the different types of the bleeding in pregnancy. If it occurs in early pregnancy, this is due to different causes of abortion. Okay, if it occurs after delivery of the baby, this is a different topic. We talked about it in the last class, like postpartum hemorrhage. Today we are talking about the antepartum hemorrhage. Okay, so the anti is before, partum is the process of delivery. So it is the hemorrhage which occurs in the female genital tract before the birth of the baby. Antepartum is the before the birth of the baby. So definition of antepartum hemorrhage is simply as simple as bleeding which occurs before the birth of the baby. And before the birth of the baby can be of like at 5 weeks of pregnancy, it can be of at 40 weeks of pregnancy. Okay, you have covered a class with bleeding which occurs before 28 weeks of gestation. This is related to abortion. Okay, so this is the period of viability. Nowadays, we take the period of the viability is at around 20 weeks of gestation. So definition has changed. If in our part of the world, the period of viability is taken as 28 weeks of gestation. So any bleeding any bleeding which occurs after 28 weeks of gestation and before the birth of the baby is called antepartum hemorrhage. Okay? So the bleeding during pregnancy can be related to pregnancy, or that can be not at all related to pregnancy. So that can be divided into different headings. If it is related to pregnancy, that is which occurs after 28 weeks of gestation and before the birth of the baby, is simply as simple as the definition of APS is bleeding after 28 weeks of gestation. Okay, so bleeding from anywhere, from any part of the body, any organ, bleeding occurs due to trauma. Okay, another thing is any type of inflammation which occurs in that particular organ, or any type of neoplasia sometimes can cause bleeding. Okay, different types of neoplasia, that can be of the benign neoplasia or the malignant neoplasia, that can sometimes cause bleeding. So any bleeding, any part of the body, any organ, if it bleeds, you have to think about different causes like trauma, inflammation, and neoplasia. Besides that, in pregnancy, this is related, not related to the exactly to the trauma. If it is related to the pregnancy, the causes are different. Okay. So bleeding which is related to pregnancy can be of the placental causes or extra placental causes. Okay, if you talk about the placental causes, most of the time, most common cause of the bleeding in pregnancy which occurs after 28 weeks of gestation is caused by placenta previa. This is a big heading, big topic. Another is the placental cause is the abruptio placenta, which is again another big topic. So these are the two different causes which are related to placenta and is related directly related to the pregnancy. Okay. Extra placental causes like that can happen in pregnant ladies are due to the because of the congestion in the pelvic organs, that the structures become so much soft and that can bleed easily. Most common cause, extra placental cause of bleeding in pregnancy is like bleeding from the cervix, which is very soft and which is very congested, that can be bleed easily anytime. So that is the different types of the lesions in the cervix which is related to pregnancy, like cervicitis, which chances of cervicitis is increased in pregnancy. Another thing is if the cervix is congested, and along with that congested cervix, if there is a cervical polyp, pre-existing cervical polyp, which is a type of neoplasia that can bleed easily in pregnancy. If it is if it is in the non-pregnant ladies, that does not bleed, because in pregnancy, because of the vascular congestion, that cervical polyp can bleed. Okay. Another extra placental cause of bleeding in pregnancy is a vasa previa bleeding. We'll talk about it later. So this is just have a closer look on this figure. This is the vagina, okay, and this is the cervix. Cervix is this is the external os. This is the internal os. Okay. If you talk about the pregnancy related bleeding, that can like trauma can happen anywhere from the introitus to the vagina and the cervix. Okay, and cervix again in a different part of the cervix, endocervix or ectocervix. If there is trauma, there is a chance of bleeding. I'm talking about the non-pregnant related bleeding. And neoplasia can happen anywhere from the introitus, in the vagina, in the cervix. Like just talk about cervical polyp, which is a type of the benign neoplasia in the female genital tract. Okay. Third is the like inflammation can occur in any part of this female genital tract. So these are the extra pregnancy not related causes. Okay. If it is related to pregnancy, this is the gravid uterus containing fetus and the placenta. Okay. So this is the placenta which is localized in the upper uterine segment. Lower uterine segment is the part over here. If the placenta is here, this is abnormal placentation. Okay. Normally, the placenta lies in the upper uterine segment. We talked about it in earlier classes also. If the placenta is here and the baby is here, this is normal scenario. In last class also, I told you if a pregnant lady bleeds from the uterus, this is always from the placental attachment site. She does not bleed from here. She does not bleed from here. She does not bleed from here. Okay, so she bleeds from here where the placenta is attached. Okay, so if the pregnant lady who is having bleeding, she has carrying a fetus inside the uterus and she is bleeding. That means you have to rule out all the other non-pregnant related causes that can happen in pregnancy also, but that can be aggravated in pregnancy because of the pelvic congestion. And after rule out of this, all the other causes of the bleeding from the lower genital tract, you have to think about the upper genital tract bleeding. Most common is the placental causes, and from the placental site, she bleeds. Okay, you have to think about the bleeding from the placental site. Okay. So this is a initial early stage of the pregnancy. I told you if the pregnant lady with a gravid uterus, if she bleeds, she has bleeding from the placental attachment site that I have already talked about it, how the patient bleeds from the placental attachment site, because there are big venous sinuses here. And if there is something wrong, if the placenta starts bleeding and there is no uterine contraction and the big venous sinuses gets open and the patient will have bleeding. That applies to the postpartum hemorrhage and as well as in the antepartum hemorrhage. So if the patient is bleeding with a gravid uterus, after ruling out all the causes of the other causes of the bleeding, you have to think about the placental causes, and these are the sites where patient bleeds in pregnancy. Is it clear? Yeah? Are you there all? Okay.
Yes, ma'am.
First, most important classification of the antepartum hemorrhage or the cause of the antepartum hemorrhage is placenta previa. Simple as if the placenta is implantation of the placenta is in the lower uterine segment with a different grades over the internal os. That means the placenta is not lying just in previous placenta is not lying in the upper uterine segment. This is lying in the lower uterine segment. Okay, normally I told you the placenta lies in the, just like here, placenta is in the upper uterine segment. In placenta previa, what happens is the placenta is lying in the lower uterine segment, where the head is supposed to be there. Okay, most term lower uterine segment, the head is there. Okay, so in placenta previa, if the placenta is lying in the lower uterine segment instead of the upper uterine segment or in the fundal region, is here covering the internal os of different grade of encroachment to the internal os. This is called placenta previa. Okay. So there are different classification of the placenta previa, different types of the placenta previa. It depends upon the how much of the internal os is covered by the placenta. Suppose this is the internal os, okay? If you see from this is the internal os, and grade one or the type one placenta previa is the placenta is in the lower uterine segment, but it has not touched the internal os. Just encroachment is just at near to the internal os, but it has not covered the internal os. Okay? There is some disturbance. Can you mute? There is some disturbance. Okay. Type 1 is the placenta is low-lying placenta. Placenta is in the lower uterine segment, but it looks like if you see from below, this is the internal os. This is far away from the internal os. This is the type 1 placenta previa. Type 2 placenta previa, this is like very near to the internal os if you see from below. The on above picture, most of the placental tissue is in the lower uterine segment. Okay, slightly there is some placental tissue is in the upper uterine segment. There is a boundary of the upper uterine segment and the lower uterine segment. We'll talk about it later. In this figure, in this type 2 placenta previa, what happens is like most of the more than 50% of the placenta is in the lower uterine segment, and small part of the placenta is also in the upper uterine segment. This is the type 2 placenta previa. It has got two types. One is type 2 anterior and another is type 2 posterior. This is a posterior, type 2 posterior placenta previa, where the placenta is implanted on the posterior wall of the uterus. Okay. Another is this placenta can be placed in the like implanted here in the anterior wall of the uterus. Why this is divided into two parts? It has got significance. What significance is like if the placenta is of the type 2, what happens is there is a sacral promontory. Okay, this is just covering just in front. It lies in front of the sacral promontory, and if it is of the posterior type 2 placenta previa, it decreases the anterior posterior diameter of the pelvic inlet. So engaging diameter is becomes small if it is on the type 2 posterior placenta previa, but that does not happen in the anterior type of the type 2 placenta previa. Okay, so this is taken as a dangerous type of major degree of the placenta previa, which is the type 2. Posterior is a major degree. Why this is major degree? It lies in front of the sacral promontory and it decreases the anterior posterior diameter of the pelvic inlet, so there will be problem on engagement of the head, and sometimes the engaging head can cause pressure to the placenta and the baby can go into hypoxia because of the pressure to the placenta because of the disruption in the uteroplacental circulation. So this is taken as a major type of the placenta previa. Okay. Third type of the placenta previa is like all of the placenta is in the lower uterine segment, but if you see from below, there is some like anterior part is open. Okay, this is not covered. So this is not covered means this is the type 3 placenta previa. Okay, and type 4 placenta previa is the placenta is whole of the placenta is lying in the lower uterine segment, covering completely internal os. Okay, in this figure, what happens is the whole of the placenta is over the internal os. This is the type 4 placenta previa. Okay, to make it easy and to divide according to the risk of the placenta previa in pregnancy and the delivery, this is divided into mild degree of the placenta previa and major degree of the placenta previa. Mild degree of the placenta previa is the type 1 placenta previa and type 2 anterior placenta previa. Major degree of the placenta previa is the type 2 posterior. I told you why. And type 3 and type 4, they are taken as major degree of the placenta previa. So this is based on the according to the effect on the baby and along with that effect on the mother also. Okay. So in clinical background, if the patient comes with placenta previa, you have to divide into the two degrees to plan for delivery, which degree of the placenta previa this patient has. Okay. this is the cross section of the patient with the uterus with the placenta previa. This is the uterine cavity. This is the complete placenta previa. This is the internal os, and this is the external os. So it has covered whole of the internal os. Whole of the placenta is in the lower uterine segment. This is placenta previa. Okay. So these are, I have already told you, type 1, type 2, type 3 and type 4. Type 1 is called the low-lying placenta. It has just touched the placenta, lower edge of the placenta has just touched the lower uterine segment. Type 2 is the marginal placenta previa. Type 3 is the incomplete placenta previa, and the type 4 is a central or complete placenta previa, where the placenta is lying just over the internal os. According to the classification, these are the dangerous type of the placenta previa, 3 and 4, and type 2 posterior. Okay. What are the clinical features if the patient has placenta previa? Patient is pregnant, but she has abnormal placentation, which has to be there in the upper uterine segment. It is lying in the lower uterine segment. Okay. So what happened is, pregnancy beyond 28 weeks of gestation, patient complains like if the patient has antenatal checkup, regular antenatal checkup. That's why the importance of antenatal checkup is there. You have to, if you see the placenta in the lower uterine segment, you have to explain certain alarming features to the patient, so she can come to you as early as she develops symptoms. Okay. Patient who has 28 weeks of gestation and above beyond 28 weeks of gestation, sudden onset of the bleeding per vagina. Okay, this is a sudden onset of the bleeding. It's not like patient has scanty bleeding for a long time. She is tolerating, she is eating, she is working her job, she is going for job, everything she is doing, but she has scanty bleeding. This is not the scenario in the placenta previa. She has profuse bleeding, which is sudden onset. She was all right a few minutes ago. She started bleeding like anything. Okay, so sudden onset of the bleeding per vagina, but at the same time, patient has bleeding, but patient has no pain abdomen. Okay. Another thing is like if you see the causes, like if patient is in regular antenatal checkup, has you don't have any anticipated cause of bleeding per vagina, just like patient has cervical polyp or things like that. There is no history of the trauma. There is no other neoplasia. There is no infections. There are no obvious detectable causes in extra pregnancy related to the pregnancy in that particular patient. So no obvious cause is found like trauma, infection, and neoplasia in that particular patient, and the bleeding is very profuse and bright red bleeding. Okay, bright red color bleeding. Okay, so this is the clinical scenario of a patient who has placenta previa. Always think about the patient of 28 weeks above pregnancy. It can happen before also, but it becomes more obvious after 28 weeks of gestation. Why this is more obvious after 28 weeks of gestation, I'll tell you. What happened is that in the before 28 weeks of gestation, or during the first half of the pregnancy, as the pregnancy advances, the upper uterine segment becomes expanded, like it's stretched out. Okay. After 28 weeks of gestation, the lower segment of the uterus starts stretching out. That means the formation of the lower uterine segment occurs only after 28 weeks of gestation. There is nothing to do with the in the first half of the pregnancy. The lower uterine segment is inactive. As the pregnancy advances and it reaches 28 weeks of gestation, the lower uterine segment becomes active. That means a stretching of the lower uterine segment. Okay. So when there is stretching of the lower uterine segment, as I told you in the third stage of labor, the mechanism of the separation of the placenta, what happens in the third stage of labor? The uterus is contracting. That means the site of the uterus where the placenta is attached becomes smaller. Okay, so it helps in the shearing force develops in between the placenta and the uterus at that time. But in antepartum hemorrhage, there is no contraction. There is relaxation of the lower uterine segment, or the stretching of the lower uterine segment, which causes the increase in the surface area of the lower uterine segment, where the placenta is attached. Okay, so this is the clinical scenario of a patient who has placenta previa. Okay, so 28 weeks of gestation. In placenta previa, if the first episode of the bleeding, which occurs at around 28 weeks of gestation, that bleeding is called the sentinel bleeding. The bleeding cause is called sentinel bleeding. Okay. Another thing I want to tell you why it is painless. Patient is having profuse vaginal bleeding, but she has no pain at all. Okay, in pregnancy and after delivery, the pain which is perceived by that particular female is due to the uterine contraction. Okay, in placenta previa, there is no uterine contraction. The bleeding is not due to uterine contraction, but that bleeding is due to stretching or the relaxation of the lower uterine segment. So this particular patient who has got bleeding PB, she has no uterine contraction, so she has no pain abdomen. This is very important to know. Okay. Another important thing in placenta previa bleeding is blood is bright red and profuse amount of blood. Okay, this is bright red. I'm giving stress on the bright red bleeding. Why? Because that blood is coming from just above the internal os. Okay, it has no time to be accumulated there and to become dark red. So this is a fresh bleeding which is coming just above the internal os, which is very near to the vagina. As soon as there is separation of the placenta, it comes to the vagina and the patient notices bleeding. So this is a bright red color. Three things you have to understand. It occurs at around 28 weeks of gestation. There is no pain. I told you the reason. And this is a profuse bleeding and a bright red color bleeding because it comes just above the internal os. There is no time for accumulation. So it does not become dark. This is a profuse bright red bleeding. So these are the most important characteristic of the placenta previa bleeding. Okay. So I told you this mechanism of the bleeding in placenta previa. I told you everything in the I told you as the pregnancy advances, uterus stretching more in the upper segment in the first half of the pregnancy. Second half of the pregnancy, it becomes more active. Lower segment becomes more active. That means start stretching out, and stretching causes an increase in the surface area of the lower segment at the site of the placental attachment, and the placenta surface does not increase in size. I told you, and there is a shearing force development in between the placenta and the uterus, and the placenta gets detached, and the big sinuses which are lying just behind the placenta in the uterine wall, they get opened and the patient starts bleeding. This is how the placenta is separated in the antepartum hemorrhage, particularly in the placenta previa. Okay? I think this is clear. So typical characteristic of the bleeding, again I told you this is painless bleeding. I told you the reason why this is painless, associated with there is no uterine contraction. Bright red bleeding, why this is bright red, I told you this is coming just above the internal os, very near to the vagina, so there is no time for the collection to be dark, to be dark color bleeding. Okay, these are the characteristic of the bleeding in the placenta previa. Okay. Severity of the bleeding in last class also I told you, in any type of the bleeding there is like classification. It depends upon the amount of the blood loss. If it is less than 500 ml, 500 ml or more, this is the percentage of the blood volume in loss about 10 to 15%. It applies to everywhere. I have shown this slide in the postpartum hemorrhage also. This is the same as the patient becomes symptomatic when there is loss of more than 50% of the around 50% of the total blood volume. Patient is in the severe shock. That you have to know about this. Okay. Type of the presentation. What type of the patient comes to you with placenta previa and the bleeding? Patient can be after having regular antenatal checkup. She is aware of the placenta previa, diagnosed case of the placenta previa. She was doing all right during the pregnancy. At around 28 to 30 weeks of gestation, she suddenly develops a bleeding PV and she comes to hospital. This is one scenario which occurs in the regular booked case. That means the regular antenatal patient. Another unbooked case, that means the patient was not having antenatal checkup. She has no ultrasound done. She doesn't know about her pregnancy status and the placentation where the placenta is located, that patient comes to you directly to the emergency with bleeding PV. These are the two scenario of the scenario. Sometimes patient can be like a patient can be asymptomatic also. So very rarely can be asymptomatic. The patient is having regular checkup or not doesn't matter, but the patient comes to you in labor only. Okay, if she comes to you in labor, as the labor starts, she starts having labor pain, she starts having profuse bleeding because of the placental detachment or placental separation. That is another scenario which occurs like if the patient was all right throughout the pregnancy, starts bleeding at pregnancy in early stage of labor, which is profuse, and the placenta, if you do ultrasound, the placenta is in just above the internal os. This is the third scenario we see in placenta previa. So once you diagnose a patient with placenta previa, like patient pregnant lady who has got placenta previa and has having bleeding, okay, how do you manage a case of placenta previa? Okay, placenta previa is a scenario, it's a dangerous scenario. The patient can have a profuse bleeding, and to stop that bleeding, patient must have uterine contraction, and if before the birth of the baby, that is not possible. So you have to be very careful while managing a case of placenta previa. Okay. First of all, general rules which applies to all the bleeding cases is always like call for help. One patient, one health personnel cannot manage a case of obstetric bleeding. Okay, call for help. Keep the patient warm, and patient keep the patient nil for oral. Confirm the gestational age. What is the gestational age of the patient? She can be of the 28 weeks of gestation. She can be of the 34 weeks of gestation. Can be of 40 weeks. You have to first make out to confirm the what is the gestational age of that patient. Monitor the bleeding. If it is not audible, you have to go to the not if it is not audible, you have to go to the you have to manage accordingly. So see the size of the fetus. This is whether this is corresponding to the uterine gestational age or not. Like maybe the baby is too small, maybe the baby is getting hypoxia for a long time. Chronic hypoxia can cause IUGR, and the management will be different. And another thing is the establish the diagnosis. How do you establish a diagnosis of placenta previa? Is always by ultrasonography. Clinical diagnosis is impossible in placenta previa because you have to see the placement of the implantation of the site of the placenta, whether this is in the fundus or in the lower uterine segment. So to confirm that, you have to do ultrasound to find out where the location of the placenta. If it is in the lower uterine segment, this is the placenta previa. So the diagnosis is confirmed diagnosis is only with ultrasonography. That can be done transvaginally or can be done transabdominally also. Okay, and find out next thing, you find out whether the patient is in labor or not. Patient at the time of the presentation, if the patient is in labor, the management will be different. If the patient is not in labor, the management will be different. And explain after establishing the diagnosis of that particular patient, you have to explain everything to the patient and patient party who is available about the prognosis of the condition. Okay, so these are the general rule. You have to be very careful while managing a case of placenta previa, because placenta previa can cause harm to the baby as well as to the mother. You have to explain to the patient party very carefully, because nowadays it's difficult to work. You have to establish the diagnosis very carefully and then go ahead. Okay. First aid management is done for all the bleeding cases, just like insert two wide bore cannula. Okay, you have to open two veins at the same time, and the same blood for CBC and grouping if it is not done, and for cross matching, immediately start whatever fluid is available. Since the patient is bleeding, you have to replace that fluid, as if the blood is not there, it takes time to do arrangement of the blood and cross matching. You can start with whatever fluid is available. If it is like crystalloid solution, this is the better option, and arrange the blood as early as possible, and provide 100% oxygen to the patient via mask, which delivers more of the oxygen to the patient. Since the patient is bleeding, oxygen carrying capacity is decreased, so you have to give 100% oxygen with mask. Another is the patient is maybe in the shock. The patient has cool and clammy extremities, you have to warm the patient, keep the warm the patient, insert Foley's catheter for two reasons. I told you in the other type of bleeding also, in postpartum hemorrhage also, in third stage of labor also, always Foley's catheter should be there because it monitors the urine output, which gives idea about the renal perfusion. One thing is that. Another thing is that the patient is unable to go to the for voiding. You have to see the like patient can, if the patient cannot void, then you have to drain the urine for that particular reason. So there are two reasons, and in case of okay, there are two reasons. You have to insert Foley's catheter and monitor blood pressure and pulse every 15 minutes, and monitor urine output every hour to see whether there is a renal, adequate renal perfusion or not. Okay, so these are the first aid management for done for the all the bleeding patient. We do the same thing in the obstetric hemorrhage also. Favorable situation and unfavorable situation in placenta previa. First of all, if the patient has scanty bleeding, okay, scanty bleeding or the she had profuse bleeding, it stopped and becomes like it becomes lesser and lesser. That is the favorable situation in placenta previa. Another is fetal condition is good, but not fetus is not mature. Okay, if the fetus is of like less than 37 weeks of gestation is not like we take it as like preterm pregnancy and the baby is not matured. If it is like if it is less than 34 weeks of gestation, the long baby long is not matured. So we our aim is to reach if the depending upon the time of the presentation, if the patient is at presented to us at 28 weeks of gestation, our aim is to reach up to 34 weeks of gestation if possible. Okay, and if that becomes favorable, we our aim is to reach 37 weeks of gestation. So that means the term pregnant, to achieve term pregnancy and to have term baby which has got less complications and output is good. Okay, so favorable situation can be if the maternal condition is stable, baby condition is good, and we give for that those patients who has scanty bleeding or stopped having bleeding after first episode of the bleeding, then we give tocolytics to prevent labor. If sometimes the patient continues bleeding, prostaglandins are released, and those prostaglandins acts on the uterus and it causes uterine contraction. Patient can go into labor. So to prevent that, we give tocolytics, which prevents the patient going into the labor by causing relaxation of the uterus. Tocolytics. Okay, we give fetal steroid for fetal long maturity at the same time, and patient if the patient compliance is good, like if you explain everything is everything to the patient and patient is ready to go forward and follow your instruction, that is patient compliance. Good patient compliance is one another favorable situation. And I told you the aim is to reach the nearest gestation, either 28 or 34 or 37 weeks of gestation. If the favorable condition is there, she can reach up to the 38 or 39 weeks of gestation also, if there is no bleeding anymore. And all facilities to terminate the pregnancy in emergency conditions, like you need OT setup, you need plenty of the blood supply, you need a good neonatal unit to help you if you need to terminate the pregnancy anytime. So this type of facilities must be there when you are keeping the patient in the admission for the conservative management and the situations are favorable. So these are the situations you can go forward and continue the pregnancies. Okay. So there are few questions that has to be answered when you managing a case. How much of the blood has been lost in this particular patient? If the patient, according to the chart I showed you, according how much of the blood, at least 500 ml or 1 liter or 2 liters or 3 liters, it depends. If the patient is if the patient is having profuse blood loss, like around 3 liters, about 30 to 50% of the total blood volume loss, and the gestational age is just 30 weeks, you cannot wait for the baby maturity because you have to terminate the pregnancy to save the mother. Okay, so it depends on various factors. Like there are 5% that needs to be urgent answer while managing a patient with bleeding PV in pregnancies. How much of the blood has been lost? According to that, what is the maternal condition? Okay, it shows in the maternal condition also. What is the duration of the pregnancy? I told you our aim is to reach at least 34 weeks of gestation, because 28 to 34 weeks of gestation, the baby outcome is not that good in our part of the world because of the that much facilities for neonatal unit is not available in our setup. So our aim is to go beyond 34 weeks of gestation, if possible. If the favorable scenario we talked about just before in the previous slide is not there, we cannot continue the pregnancy. And what is the fetal condition? If the fetal condition is good, you can continue the pregnancy. If the fetus is already in distress, doesn't matter what is the gestational age, doesn't matter what is the amount of the blood loss, you have to terminate the pregnancy. And the next thing is if the patient is in labor or not. Okay, so these are important things to find out whether to continue the pregnancy or to terminate the pregnancy at that particular moment. Okay. Indication of termination of the pregnancy. Patient is admitted in ward. Okay. You have kept in the conservative management. Wait and watch type of the management is called conservative management. Okay. So when are you going to terminate the pregnancy? That means once your patient is in conservative management, the fetal condition is good, maternal condition is good, patient is not in labor. Okay. Patient mother has no bleeding or scanty bleeding baby. So those are the patients are kept in the ward as for conservative management. So those patients, when do you need to terminate this patient? If the patient develops like goes into labor. Okay, that patient went into labor, so you have to terminate the pregnancy because you cannot stop the established labor. Okay, so preterm contraction can be prevented, but once the patient is in active stage of labor, you cannot wait for that. You cannot stop that labor. So whatever is the gestational age, you have to terminate the pregnancy if the patient is in the established labor. Okay, and if the admitted patient was kept in the conservative management is having excessive bleeding. See, yesterday she was all right. This morning on round, she is having profuse bleeding. So you cannot wait for this patient. Whatever is the gestational age of the fetus doesn't matter. You have to terminate the pregnancy for the mother survival of the mother. Okay, gestational age is equal or more than 37 weeks of gestation. That means the patient was kept in the conservative management. Patient was doing fine. There was no bleeding. Fetal condition is good, but she has crossed 37 weeks of gestation, and we have to terminate that pregnancy because we cannot stand other more bleeding, more episode of the bleeding in pregnancy, which causes hypoxia to the fetus and anemia to the mother. Once the baby is matured, then we have to terminate this pregnancy. And if there is fetal distress, like if the patient was kept in the conservative management, but if you listen to the fetal heart sound, that fetal heart sound either can be of the bradycardia or irregular fetal heart sound or the tachycardia. That means something is wrong with the fetus. The outcome of the fetus will be very poor if you keep on keeping the patient in the conservative management. You have to terminate the pregnancy. Okay. Another indication for termination of the pregnancy is if the patient has fetal death or the fetus which is congenitally abnormal fetus in ultrasonography. Okay, there is no point of carrying a fetus which has a fetal death, which is already dead fetus, and the fetus has congenital abnormalities. You have to terminate the pregnancy. So these are the points when you have to act actively for the management of the placenta previa, and you have to terminate the pregnancy if you have kept the patient in conservative management. Mode of deliveries based on the type of the placenta previa, mode of deliveries can be of the minor type of the minor degree of the placenta previa. You can go for vaginal delivery if there are no other risk factors of obstetric indication for cesarean section. Okay, just minor degree, that is type 1 and type 2 anterior are the minor degree of the placenta previa. For those patients, you can go for vaginal delivery. Okay, and major degree of the placenta previa, I told you type 2 posterior, type 3 and type 4 they are the major degree of the placenta previa, and the patient you have to go for cesarean section. If the patient has got other obstetrics indications like previous cesarean section and abnormal lie, transverse lie, breast presentation, things like that, you cannot rely on the degree of the placenta previa. You have to go for cesarean section. So mode of delivery, first established whether the patient has other obstetrics indications of for cesarean section or not. If not, then you go for minor degrees for vaginal delivery. You go for major degree like for cesarean section. These are the clean cut management mode of delivery of the placenta previa. Okay. What are the complications of the placenta previa? As you all know that this is the bleeding. In obstetrics, bleeding is always dangerous. Patient can go into shock. Okay. Complication of placenta previa, patient is bleeding. All the complication of the any type of the bleeding are there. Shock, renal shutdown, and baby can go into fetal distress or fetal death. Okay, patient who has antepartum hemorrhage due to placenta previa, that patient has risk factors for the postpartum hemorrhage also. Okay, when the placenta previa, women with placenta previa are high risk of the PPH in the placenta accreta and increta also. Okay, that are the morbid adherent placenta. We talked about it in a previous class also. And common findings at the previous sites of the cesarean section. If the patient has previous cesarean section, placenta gets attached to that previous scar, and there is morbid adherent placenta and becomes a placenta previa, complicated type of the placenta previa. Okay, so this is about placenta previa. Next, placental causes of pregnancy-related cause of the bleeding in antepartum hemorrhage is abruptio placenta. This is another big topic in the placenta in antepartum hemorrhage. This is abruptio placenta. Okay, what happened in abruptio placenta is placenta in this particular bleeding. What happened is the placenta is in the upper uterine segment. This is normally situated placenta. We just talk about it. Okay, placenta previa is an abnormal plantation of the placenta in the lower pole of the uterus. But in abruptio placenta, placenta is in the upper part of the uterus, but this gets prematurely separated from the uterine wall. So this is a premature separation of the normally implanted placenta, may be precipitated by various causes. Okay. What are the precipitating factors for the normally situated placental separation? Okay, in placenta previa, the initiating factors or the precipitating factor is the formation or stretching out of the lower uterine segment. But in abruptio placenta, which lies in the fundus, why this gets detached from the uterine wall? There are various precipitating factors. Most common is the high blood pressure. Okay, what happens is patient is having high blood pressure, chronic blood pressure, high blood pressure, which was present before the pregnancy as well. It causes atherosclerotic changes in the placental bed vessels of the placental bed, and that gets ruptured and the placenta starts separating. So this is the common cause of the abruptio placenta, which is separation of the premature separation. That is why this is premature? Because not because this is less than 37 weeks. This is premature separation is called if the patient has not delivered but placenta gets started separating from the uterine wall. So this is called premature separation, not at its own time, which has to be separated in the third stage of labor. But this is started separating in the pregnancy. So this is called premature. Okay, this is premature separation of the normally implanted placenta precipitated by the high blood pressure. Second common cause is like precipitating factor is trauma, blunt trauma to the uterus. When patient gives history of the fall, then she gets usually at around term pregnancy when a female falls down. The most prominent part is the abdomen. So there is a trauma to the abdomen, blunt trauma to the abdomen. That causes what happens that blunt trauma is like if the patient is falling in front and there is a hit on the abdomen, that particular part of the uterus gets contracted as a protective mechanism. Okay, that contracted because of the contraction, placenta starts separating. Okay, this is just like in the third stage of labor. So trauma is a precipitating factor. Blunt trauma is a precipitating factor for abruptio placenta or the premature separation of the normally implanted placenta. Okay, so what are the things you see in the abruptio placenta? Like these are the have look on these figures, like this is a normally situated placenta, this is a normal placentation, everything is normal. Okay, so this is a placenta previa where the baby is here above and the placenta is lying in the lower pole of the uterus just below the presenting part. Here is the presenting part, here the placenta is lying here. So this is complete placenta previa. Here the baby cannot be delivered from the vagina because before the delivery of the baby, the placenta is delivered. So the placenta uteroplacental circulation is disturbed and the baby becomes hypoxic. Okay, so this is the abruptio placenta. This is the fetus. Okay, placenta is in the line in the upper uterine segment, but this is detached from the uterine wall. This is a uterine wall. This is the placenta. There is a blood collection which is called the retroplacental collection. This is as a result of the premature separation of the placenta, which is the separation of the placenta before birth of the baby. Okay, this is the abruptio placenta. So this is another figure. There are three types of abruptio placenta. One is like concealed type of the abruptio placenta. Concealed, the term itself says, is the not visible. Okay, the placenta is detached from the uterine wall. There is collection of the blood in the retroplacental space, but there is no vaginal bleeding. Okay, so this is one type of the concealed type of the abruptio placenta. Okay. Second is placenta. In this concealed type of the abruptio placenta, there is a central separation of the placenta. Starts from the central part of the placental attachment and it goes towards the to the either side of the placenta. Okay? This is a concealed type of the abruptio placenta. Next is the revealed type of the apparent bleeding hemorrhage. Okay, what happens is the placenta starts getting separating from the uterine wall and it comes to the vagina. Patient has experienced vaginal bleeding. This is the revealed type, or the apparent hemorrhage is the second type of the abruptio placenta. Okay, sometimes there is both types of the combined type of the abruptio placenta. There is collection of the blood just behind the placenta, as well as there is some bleeding in the vagina. So that is the third type, which is the mixed type of the abruptio placenta. And this is another scenario where the placenta is completely detached from the uterine wall. The complete separation of the placenta, baby is hypoxia. Usually in this type of the abruptio placenta, complete concealed hemorrhage, the baby is usually dead. Okay, so these are the different types of the abruptio placenta according to the amount of the bleeding in the vagina. Can be of the concealed type, can be of the revealed type. This is revealed type, or can be of the combined types. Okay, so these are the types of the abruptio placenta. Okay, next is like how do you diagnose a case of abruptio placenta? Is like you have to take careful history, present obstetric history, and symptoms of hypovolemia. If the patient has no bleeding at all, the patient can show the features of hypovolemia. Why this happens is if this is related to concealed type of the bleeding. That means the patient has collection just behind the placenta. So concealed type of the bleeding is dangerous because the patient does not have vaginal bleeding, but patient is in shock. Okay, you have to take careful history whether if there is any type of medication patient is taking, if there are symptoms of the preeclampsia, if the patient is taking medications for blood pressure before pregnancy also. Okay, and type of the lower abdominal pain. Abruptio placental bleeding is always associated with the pain abdomen. Okay, pain abdomen. Why there is pain abdomen is, as told you, if there is trauma or if there is high blood pressure and atherosclerotic changes in the blood vessels, that particular part of the uterus where the placenta is attached, that becomes irritated and goes into the contraction. So there is uterine contraction and the patient experience pain. Okay, so type of the pain abdomen you have to carefully ask in a history in case of abruptio placenta also. Okay, and presence or absence of the fetal movements. Why this is important is usually in complete separation of the placenta, abruptio placenta. I showed you in the previous slide. If there is complete separation, the fetus is usually dead. Okay, and sometimes if the more than 50% of the placenta gets detached from the uterine wall, the baby gets becomes like hypoxic, and there is fetal heart sound, the patient experience less fetal movement. So always ask about the presence or absence of the fetal movement with a patient who has got antepartum hemorrhage. Okay, another is like uh, history of the rupture of membrane. Okay, sometimes the patient has a pain abdomen, patient has a rupture placenta, and she has a rupture of the membrane also, and she has a liquor coming out of the vagina. Okay, and may be associated with the labor pain also. Patient may be in the labor also. You have to ask the patient carefully about the features of the labor pain, what type of the labor pain she has. If the patient has intermittent type of abdominal pain, the patient is in labor, because in case of the pain which is associated with the abruptio placenta, this is a continuous type of the pain abdomen. Okay, if the patient has abruptio placenta, continuous type of the pain abdomen, and later on, if so she goes into labor, she will have intermittent type of the pain abdomen. So find out whether the patient is in labor or not by asking a typical character of the labor pain. Okay, and you have to ask about the previous uterine surgery if it is done. Okay, sometimes if the patient has a hysterotomy or myomectomy, removal of the duomyoma, that is fibroid uterus, that can precipitate the abruptio placenta. That can be the precipitating factors or the risk factors for premature separation of the normally implanted placenta. So you have to ask about the previous uterine surgery. History of the sexual intercourse just before the onset of the bleeding, that can sometimes provoke the bleeding, and you have to, like, if the patient comes to you with the bleeding per vagina, you have to inspect the lower genital tract carefully to rule out like trauma, neoplasia, and inflammation. We talked about it in the previous slides also. And if the patient gives history of the trauma, the recent trauma in this pregnancy, which provokes the bleeding or the pain abdomen. So these are the history, these are the things you have to ask carefully to find out whether the patient has abruptio placenta or the other causes of the vaginal bleeding. Okay. After taking history, you have to examine the patient. Okay, when you examine the patient, you, if you suspect blood loss, doesn't matter this is concealed or revealed type of the blood loss, you always have to see the signs and symptoms of the shock. Okay, when you look for the signs of the shock, maybe patient is tachycardic, patient has hypotension, patient has like other features of the cold and clammy extremities also. Examine a patient with abruptio placenta, your mind should be already set that these are the clinical findings which favors the diagnosis of abruptio placenta. There is abdominal tenderness in the abruptio placenta. When you examine the gravid uterus, there is tenderness. Okay? That is again the tenderness is of the localized type of the tenderness. In a certain part of the uterus that becomes tender, not whole of the uterus. Okay, so tender uterus, and which is a rigid and tense uterus. Okay, that is as a result of the uterine contraction that becomes rigid and tense, just like guarding type of the features you see on abdominal examination. When there is uterine contraction and tense and tender uterus, and it is difficult to feel the fetal parts. You cannot find out whether the head is in the lower pole of the uterus or in the upper pole of the uterus. So this is difficult to feel the fetal parts and find out what is the presentation of the fetus. So it depends upon the severity of the abruptio placenta. Okay, it is difficult to feel the fetal parts. Another thing is like the fundal height is like more than the gestational age if it is of the concealed type of the, there is some spelling mistake, I'm sorry. The fundal height is more than the gestational age. Why this is more than gestational age is if it is of the concealed type of the bleeding, there is accumulation of the blood just behind the placenta and it increases the size of the uterus, so the fundal height becomes more depending upon the amount of the blood loss or the amount of the degrees of the separation of the placenta. Fetal heart sound alters, may be absent, maybe tachycardia, maybe bradycardia, maybe irregular fetal heart sounds, or sometimes if it is of the minor degree of the separation, there may be normal fetal heart ultrasound also. Okay, so these are the abdominal findings. Most important, you have to be very careful if the patient, if your patient comes, if you suspect a patient with abruptio placenta, the abdomen is tender and tense. Fetal parts are difficult to palpable, okay, and the fetal heart sound depends upon the amount of the blood loss or the degree of the separation of the placenta. These are the very particular about the abruptio placenta. Okay. On core vaginal examination, in a patient who has got core vaginal examination and you are not sure of the implantation of site of the placenta, you are not allowed to do core vaginal examination, because if this is not diagnosed like placenta previa, if you are not confirmed about the placenta previa and you try to do core vaginal examination and try to insinuate your finger into the internal os, it causes more separation of the placenta if it is of the placenta previa hemorrhage. So if you are not aware, if you are not confirmed about the placental localization in a patient who has obstetric hemorrhage, antepartum hemorrhage, you are not allowed to do core vaginal examination. Before that, you have to confirm the placental site attachment, and then only if it is in the upper uterine segment, you can do core vaginal examination to see the features of the whether the patient is in labor or not. Okay, so you have to be very careful before doing core vaginal examination. Always localize the placenta with the help of the ultrasound and only do core vaginal examination to see the other features of the labor and other causes of the bleeding per vagina. Okay, this is very important. What are the investigation you do for the all type of the bleeding per vagina or the all type of the bleeding, okay, from any sites. So you always have to send CBC, ABO typings and things like that. And you always have to, on top of that, in a patient with abruptio placenta, in case of the concealed hemorrhage, the patient is already hypovolemic. Most common complications are renal shutdown and the patient can go into DIC in early stage. Because why? In placenta previa, patient has bleeding per vagina in early stage of separation of the placenta. But in abruptio placenta, the placenta is in the upper uterine segment. It takes time for the bleeding blood come to the vagina. So after she sees vaginal bleeding, only she comes to the hospital. Before that, she is at home. At that time, the patient is in shock and the baby is in hypoxia. Okay? When the patient is in shock and the patient will have a decreased renal perfusion and all the features of the DIC, disseminated intravascular coagulation, is possible. Okay? So you have to screen for the renal shutdown. You have to send the blood for the renal function test and all the parameters of the DIC once the patient is suspected to have a abruptio placenta. Okay? Okay, I told you about the for vaginal examination, which is not allowed before establishing the diagnosis. Okay, ultrasound. What is the importance of the ultrasound in abruptio placenta? Actually, abruptio placenta is diagnosed in clinical background. You don't need to do ultrasound to find out abruptio placenta. Only important thing is that the placenta, you have to find out the placenta in the upper uterine segment. So any patient who has got the placenta is in the normally situated upper uterine segment and all the other features of the separation of the placenta, then this is diagnosed as abruptio placenta, because minor degree of the placental separation from the uterine wall is not visible in the ultrasonography until and unless there is a major degree of the placental separation, complete placental separation, and the big chunk of the retroplacenta which is causing pressure to the placenta, only that is visible in the ultrasonography. Minor degree of the abruptio placenta, in that case you don't see anything in the ultrasound, so you diagnose the abruptio placenta with clinical findings, history and clinical findings only. Okay, so if you do ultrasound, you can see other things in the of pregnancy, just like you can see the viability of the pregnancy, localization of the placenta. This applies to pregnancy of different kinds, not in only for the retroplacental hematoma. Okay, so always remember, placenta, for the diagnosis of the placenta, okay. So how do you manage a case of abruptio placenta? like I will take 5 minutes more. Okay. How do you manage a case with the abruptio placenta, which is a premature separation of the placenta, normally separation of the placenta? There are two types of the management. One is conservative management, another is active management of the. This applies to all type of APS. Okay. Going to go for conservative management. What are the indication of conservative management? That applies to the placenta previa also. Okay, bleeding is slight or has stopped. Okay, she had bleeding but it has stopped, or she has very scanty bleeding. Okay, fetus is alive. Okay, fetus is premature. If it is mature, you have to terminate the pregnancy. Fetus is premature, you want to go further until like 37 weeks of gestation if it is possible. Okay, case of abruptio placenta, which is diagnosed only by ultrasound examination and there is no other features. Like if there is a big chunk of the retroplacental hemorrhage, but the patient has no bleeding, no shock, no tenderness, not tonic uterus, contracted uterus. That means the fetus is tolerating that much of the placental separation. You can go for conservative management. Okay. In abruptio placenta, when the clinical diagnosis is clear, or in the presence of the acute fetal distress, or do not, you always think about the if the fetus has acute fetal distress, you do not waste time doing ultrasound examination, because there is no role of the ultrasound examination for the diagnosis of the abruptio placenta. So you go for either, depending upon the severity of the bleeding, you go for the mode of the delivery or the plan of the either conservative or active management of the abruptio placenta. Okay. Rest of the management is the same as bleeding PB. As once the patient is admitted in hospital, you have to see the vital signs of the patient to see the degree of the bleeding, how much she is bleeding. You have to listen to the fetal heart sound. How is the condition of the baby? Okay. On the basis of that, you have to come to the conclusion whether to continue the conservative management or terminate the pregnancy. The indications of termination of the pregnancy is the same. These are the same indications like in a placenta previa and the abruptio placenta. Okay. What are the intrapartum complications of any type of antepartum hemorrhage? Mostly the abruptio placenta. One is, first of all, antepartum hemorrhage predisposes the patient for postpartum hemorrhage, whatever is the cause, either placenta previa or the abruptio placenta. Junsuke, the cause of the bleeding boy pani, that patient is likely to have a postpartum hemorrhage. Once the patient comes to you with APH, you have to think about the PPH and manage accordingly. Okay, so that has to be done. Okay. What are the things you do you see in the patient who is admitted for conservative management, like check pulse every 30 minutes and blood pressure and urine outputs, and see the amount of the blood loss and urine out, like investigation CBCs and hemoglobin count rate regularly once the patient is admitted in hospitals. Okay. Condition that should be met before discharge. That means the patient has delivered whatever the mode of deliveries. Antepartum hemorrhage, both placenta previa and abruptio placenta are the same. If there are obstetric indication for cesarean section, abruptio placenta can go for vaginal delivery. You have delivered the patient, there is no PPS, or if it happens, you have managed the patient. What are the things you have to make sure before discharging the patient with APS, all of the APS, like cause can be of the placenta previa or the abruptio placenta. There is no active bleeding, patient has no fever, patient has moved bowel, that means the patient has passed stool, and patient is stable general condition, satisfactory urine output, and there is no wound complication if the patient has cesarean section or episiotomy. That has to be seen before discharging the patient. Okay. The complication of the abruptio placenta, I told you, this is the concealed type patient already develops different types of complication at the time when patient presents to you. So maternal shock, fetal death, uterine atony causing postpartum hemorrhage, amniotic fluid embolism that can happen in abruptio placenta, coagulopathy like in the disseminated intravascular coagulation, and most commonly renal perfusion combo, renal failure. Okay, so these are the complications of the abruptio. Okay. So this slide shows like your question out there is जस्तै हो तिमीहरूलाई ल abruptio placenta, difference between the abruptio placenta and the placenta previa. You have to know. Okay. First of all, in the causation of abruptio bleeding in abruptio placenta and the placenta previa different हुने भयो. Okay. What happens is localization of the Yeah, you slide in further. Now, just make sure there is a placenta in the upper uterine segment in abruptio placenta. Placenta is in the lower uterine segment in placenta previa. One thing is that. Okay. Another thing is that patient presents with abdominal pain in abruptio placenta. I told you because of the contraction of the uterus, and in there is no pain in placenta previa. I told you this is relaxation of the lower uterine segment. And the bleeding in abruptio placenta is usually dark red. I forgot it to mention because it comes all the way from fundus. And in placenta previa, there is fresh blood, which is bright colored blood because it is coming just above the internal os. Okay. Complication. If you talk about the complication, the more of the complication are seen in the abruptio placenta than the placenta previa. Okay, because placenta previa comes to a patient comes to hospital in early stage of the bleeding. In our group, placenta patient comes to hospital in late stage of bleeding because the bleeding late stage of the condition because there is in initial stage of the condition there is no bleeding, so patient does not seek medical help. Okay, so and the fetal distress which is common in our group placenta and is in placenta previa. Once the patient starts bleeding, she comes to you and we will manage the case accordingly. The fetal distress is comparatively less chances of fetal distress in placenta previa. Okay, there's another term I just mentioned this term vasa previa bleeding, which is the extra placental type of the bleeding which occurs in the antepartum hemorrhage. I just want to show you this slide. What happened is that these are different types of the abnormal placentation. Okay, this is a chunk of the placenta. There is another chunk of the placenta. There are certain blood vessels running from one placental chunk to the another chunk. Okay, if this chunk, if this part of the membrane is lying just above the internal os, and if we do artificial rupture of the membrane, we injure these vessels. These are the vasa previa vessels. Okay, if these vessels are injured and the patient starts bleeding before birth of the baby, this is called the vasa previa bleeding. Just make sure these are due to injury to the blood vessels which are traveling in the membrane lying covering just above the internal os, and we do artificial rupture of the membrane, and these vessels are injured and bleeding. There is bleeding. Always you have to think about MCQ also. Vasa previa bleeding is always fetal bleeding, not a maternal bleeding. This is a dangerous condition. If there is vasa previa bleeding, there is a fetal bradycardia and fetal distress and fetal death. It takes around few minutes. Okay, so always you have to make sure if that is vasa previa bleeding, if you do artificial rupture of the membrane and there is a patient starts bleeding and there is bradycardia along with that bleeding, that is vasa previa bleeding because vasa previa bleeding is always fetal blood and the baby gets like a hypoxic very soon if it is ruptured. Okay, so this is how it happens. Like this figure shows this is the presenting part. Head is there. There are few vessels traveling in the membrane lying just above the internal os. We do artificial rupture of this membrane. While doing rupture of this membrane, these vessels has ruptured and there is bleeding. Okay, so fetal blood loss is there, fetal anemia will be there, fetus hypoxia will be there, and fetal death will be there. Okay, this is the vasa previa bleeding. You don't need it in detail, but you should know in vasa previa bleeding, this is always fetal bleeding and perinatal mortality. That means the baby dying during delivery or the immediately after delivery is around 50 to 75%. Okay, so this is all about the antepartum hemorrhage. Okay, these are different types of blood vessel traveling just above the internal os. Okay. Okay, I showed you this also. Diagnosis, how do you diagnose? Like there is bleeding and the fetal bradycardia is there. So this is the diagnosis of vasa previa bleeding. Okay, thank you. Any questions?